today. First of all, I would like to thank the organizers of TOSCON for giving me the opportunity. I would like to name my case, Taming the Leak, Tenon's patch graft in corneal perforation. This is a case of a 59-year-old female who had come to our OPD with a diminution of vision in the left eye since 1 week. There was no history of any trauma. She had a history of both eyes cataract surgery done 3 years back. She was a hypertensive who was on amlodipine. If you look at her right eye, it was pretty much the cornea was clear. There was a faint crescentic shaped scar on this side from 10 o'clock to 8 o'clock, and there was a scar here also, and it was a pseudophakic eye with a best corrected visual acuity of 6/9. The left eye was the affected eye, in which you could see there was a linear crescentic perforation which was in a scar, which was more than around, it was around 2 to 3 mm, and the surrounding cornea was looking clear, and she was pseudophakic in this eye too. With this, we came with a provisional diagnosis of left eye sterile corneal melt, secondary to probably a peripheral ulcerative keratitis. The management strategies for dealing with the corneal perforation include tissue adhesive and bandage contact lens, which induces a vascularization. I will tell you about the pros and cons of all the management strategies in the next slide. The other strategies could be multi-layered AMG, a corneal patch graft, or a Tenon patch graft. Now, if you look at the pros and cons of various options, first thing is the tissue adhesive. First of all, if you are working in a resource limited settings, sometimes if you don't have a tissue adhesive, then it could be a problem in handling it. And also for perforations which are more than 1 mm, tissue adhesive might not be the right option. Also, it induces a lot of vascularization. The other option would be a multi-layered AMG. Again, having an AMG connecting yourself to an eye bank would not be possible for everyone. The other option would be a corneal patch graft. Though an eye bank resource is also an important thing, in this case it would be an overkill because the perforation was very small, and the surrounding cornea and endothelium looked very good, and also that if we are considering that this patient has peripheral ulcerative keratitis, so probably she will be we have to rule out autoimmune diseases. So doing a patch graft without immunosuppressing her would kill the graft. You will not, the graft would not survive. So we thought we would go ahead with Tenon patch graft, which is readily available. We could harvest it from the patient's eye, and it is very much proven to be useful in perforations which are more than 2 mm. So, Tenon patch graft procedure was introduced by the RP Center, Dr. Rasik Barpai et al., and it was popularized by the LVPI group. In this, we do a small bleb and we lift up the conjunctiva. We harvest the Tenon. The size of the Tenon, you can adjust it according to the size of perforation. Then you take up the Tenon tissue and plug the perforation either with glue, and then you stabilize that tissue with the help of cross sutures. You form the AC by plugging off, by removing off any iris plug, by sweeping off the iris from the perforation with the help of a iris repositor, and form the AC. So, in our case, we thought we would go ahead with our plan of management was to do a left eye Tenon patch graft under local anesthesia and follow up the patient, send her for a rheumatology consult in the immediate post-op period. So, we were planning to retrieve a Tenon from this area, and then this was the site of perforation. We would harvest this, and we were planning to put it with a cross suture. This was the post-surgery picture. So, at this end of the surgery, the AC was well formed with an air bubble, and we had to, since it was a crescentic and it was in a left inferonasal location, it was a little tricky to do all the sort of cross sutures. So, multiple sutures were kept to keep the Tenons in place. Rheumatology consult was a key in completing our diagnosis. She was diagnosed to be having rheumatoid arthritis. Her RA factor was very high, and then she was started on hydroxychloroquine, methotrexate and Vislone by the rheumatologist. So, we revised our diagnosis as left eye status post tenon patch graft for a sterile corneal melt secondary to rheumatoid arthritis. This is a 1 week post-op picture. You can see that the edema of the tissue has come down. We have put the patient on topical steroids with antibiotics, and at 1 week we had tapered the steroids. There was a BCL and the patient was kept on BCL because there was some foreign body sensation for her. At 6 weeks post-op we removed the BCL and then we stopped the steroids, and prophylactic antibiotics were kept for 1 more week, and she regained good vision. So, take home points from my case is systemic evaluation and careful history taking is the case to comprehensively manage a case, and since tenon patch graft is autologous, it avoids donor dependency and it is low cost, feasible in resource limited settings, and it provides a reliable solution for small to moderate corneal defects, prioritizing the structural restoration and visual rehabilitation. Thank you.